Once we've heard our very own Dr. Sandip Mondal speak to us. Dr. Mondal comes to us from Bengal itself. I think he's based in Birbhum. That's where I spent the last 2 days. And Dr. Mondal is going to speak to us. He's a scientist with the ICMR, and he will tell us about using data for forecasting and formulating strategies. Dr. Mondal.
Hi, good afternoon. I am going to discuss about the importance of district level data for preparedness of third wave of COVID-19. Next. We have been aware of the second wave that hit India with a very devastating way in actually last 2 months ago. Now, there has been increasing speculation of third wave. But predicting third wave is very difficult. Means questions are coming: how severe the third wave would be, when it would come, if it comes, then how long it would continue, etc. It is very difficult to predict with certainty, but we can examine some hypotheses based on the available data by applying our knowledge on basic epidemiology. For this, we have developed a simple model. Next slide, please. By capturing the essential features of SARS-CoV-2 dynamics. So those who are not aware about this kind of modeling, for them I can say that I can brief it in this way, that we divide the whole population into some compartment, like the boxes here presented. We see E or U, these boxes we can see here. So here we kept all the populations, those who are uninfected, kept in the U box here. Then after getting infection, they can move from U box to E box. Subsequently, they can pass through different other boxes depending on the those boxes represents actually the disease status of individuals. Now this we also consider the age dependency, as we know that death depends on the age of different individuals for COVID disease. So we have divided each compartment into different age groups. So these layers actually represent different age groups, and we consider we have also taken into consideration the contact between different age groups, how people mix with each other. These are important factors. Now, how rapid the disease will progress from one progress, that means how the people from one compartment moves to the next compartment, depends on the rate of transition between this compartment. Sorry, go back to the previous one. Yeah. So the compartment. Now, the number of people, how many people will be infected at a time, or how rapidly they will get the infection, depends on the how many in the say uninfected compartment, as well as how many are in the infected compartment, how they are interacting during the interaction, as well as the variants transmissibility, the virus transmissibility, how it translates the disease from one to another. So these actually we usually use a term called R0, or basic reproduction number, which will determine how fast the disease will progress from one compartment to another compartment. Next slide, please. R0 actually represents R0 means number of secondary infection that a single infected host can generate, means can spread, means how one infected person can spread the disease to how many people actually, if all are susceptible in the community. Next, basic reproduction number. This is called basic reproduction number, or R0. This depends on the rate of contact between susceptible and infected individuals, as well as the transmissibility of the virus and mean infectious period. So, for example, if R0 equal to 2, that means within next 2 generation, we can see 4 people will be infected. If R0 equal to 3, for higher R0, within third generation, we can see from here that 9 people will be infected. But how long this infection continue, means that means it will infect the all populations? No, that is not true, because when one people infect the others, and then simultaneously most of the people will be recovered with some immunity. So though value of R0 may be 2 or 3, but simultaneously as the infection spreads, the pupils will be recovered, or immune compartment, pupil in the immune compartment will also increase. So gradually, after certain time, what happens? There is no one to spread the disease. Though he or she is capable of spreading the disease to 2 or 3 people, but surrounding him or her, there is no one to spread as they are immune. So therefore, there is some threshold after which we see that epidemic curve to decline. It depends on the value of R0. If R0 is higher, then the threshold would be higher. If R0 is low, the threshold would be lower. Say for R0 equal to 2, normally the threshold is that means it can infect about 50% of the population. But if R0 equal to 3, it can infect about 66% of the population, considering all the or homogeneously distributed populations. So these are the threshold value. Again, one more important information comes for the R0 is that say the effect of that lockdown, or there are several interventions taken place during the first and second epidemic, we know. So during that period, we actually reduces the contact between individuals, therefore reducing the R0, and the epidemic curve peak can reduced by this way. But whenever we remove the lockdown, again R0 comes back to the original position, because the pupils again interact each other, and therefore the infection can grow up. Next, please. Now I am coming back to our models again, modeling outcome. From the model, actually we tried to fit the model with the existing data set. Say for location A, we consider 2 locations, location A and location B. Say for location A, we calibrated the model, is called model calibration. We calibrated the model with the seroprevalence data obtained in the early September 2020 for the first wave, and we tried to fit what R0 value, what basic reproduction gives me this curve, where the seroprevalence in September would be 7%. Similarly, we also know at location A, the second wave peak was 5-fold higher than the first wave peak. Accordingly, we estimated the R0 value for the second peak. This way, we calibrated the model. See the left-hand side figure, where the blue line curve with the uncertainty interval shows the first wave peak and second wave peak. And the bar plot at the bottom, the greenish line, those are actually bar plot, though it not looks like actually the reported number of cases per day. And in the location P, see the seroprevalence in early September was much higher than the first in location A. This here about 14% seroprevalence early September, but second wave peak was much lower in compared to the location A. Here only 1.5-fold higher than the first wave peak for location B. Therefore, we had with the calibrated model, we can see that the peak size was different, and we had calibrated with the R0 value for the first and second peak for the 2 locations. Now we can estimate, what we can do, that we can project the third wave under different scenarios, and we can look after what could happen in location A and location B. According to that, we can prepare ourselves for the third wave. Next slide, please. Third wave might generate in mainly due to 4 reasons. What are those? One is that depending on how long the immunity lasts, already some people has got immunity due to first wave infection or second wave infection. So how long that immunity lasts, depending on that, the third wave might come. If the immunity lasts say for 3 months, then the third wave might come early. But if it lasts longer, then the third wave might come later. The second reason might be immune escape scenario. This is actually a scenario where the new variant comes. If one new variant emerges, which can escape the existing immunity, then the third wave might come. The third reason is if some new variant comes for which the R0 value is much higher than the previous previous wave, then the third wave might come. The fourth scenario is the lockdown or release scenario, where the lockdown was very strong, lockdown or the restrictive measure what was taken for different states, where that was very strong and early. There actually many people remain susceptible. Now, after releasing the lockdown, third wave might arise. These are the four reasons where the third wave might arise. Next slide, please. Now I will explain the immune escape scenario, not the all four scenarios, but I will explain only two scenarios. One is immune escape scenario. See, for location A, what could happen for the third wave. Here we assume that in September, new variant will come, early September, suppose which has capability of escaping immunity by 25%. The green line here, that green shaded area at the bottom, that actually represents that the third wave scenario. We see that there will be no third wave at all if the immune escape is 25%. But if the immune escape capacity is 35%, we can see a third wave in location A. The same thing would happen in B, but with higher intense. Means here the location is different. Though the variant is same, the same variant would arise at the same time. We can see a bigger third wave for location B. Next slide, please. Similarly, if one variant comes which has more R0 value, say R0 equal to 4, then we can see for location A there is no third wave, but R0 equal to R0 equal to 5, there is no third wave. But for R0 equal to 6, there is a third wave, though the peak is not much higher. But for location B, we are seeing that the third wave might be affecting much, would be much bigger than the second wave. That is also possible. Next slide, please. Now, if we assume that one variant will arise which has immune escape capacity as well as it has more transmission probability, means R0 value is much higher, both together. We don't know what kind of variant will come if emerges. So if that arises, then what would happen? Let's see now. Next slide, please. So this is the scenario where we consider that R0 equal to 4 as well as 25% immune escape scenario. Though in the first case, when only immune escape was 25% in location A, there was no third wave. But here we have simultaneously immune escape capacity is 25% as well as R0 value equal to 4. So we are seeing a bigger third wave, though it is lower than second wave. But it is more means much higher peak than what we expected. We have seen earlier. For location B, it is always higher than the second wave. Next, please. Simultaneously, we know that vaccination. Sorry, previous one. Go back. Yeah. So simultaneously, we know vaccination is also going on. If 40% people would be vaccinated after the first wave peak in about 3 months, then we can see that it could follow that the impact of vaccination. We can see the peak would reduce around 50% for location A, but for location B it is around 35% in location B. Next, please. So from this analysis, actually we can what are the findings now? What we have seen here? We have seen the possibilities of third waves. What are the reasons of third wave, why it would come, and most important things, this the third wave might come, but in location B, always we saw here from these slides that location B is producing always bigger third wave than location A. The reason is the past history of the waves. Early seroprevalence was lower in location A relative to location B, but second wave peak was relatively higher in location A than location B. Next, please. So actually location A was constructed from considering the scenario of West Bengal, where in early September last year the seroprevalence was about 7%. But location B is a region, is a district from West Bengal, that is Alipurduar, where early seroprevalence was about 14%, 14% now. So therefore, we can say that, next please. Therefore, we can say the third wave is unlikely at the state level, but district level scenario might vary. Means in district level, it might be substantially high third wave. So by looking at the data at the state level, we can say what scenario we will expect for the district level. District level data is important for preparedness, and also ramp up of vaccination has impact on controlling the mitigation of the third wave, and simultaneously we should follow the COVID appropriate behavior. As we know that the vaccine can only protect us from developing severity of the disease, but not on the transmission. So that's why we suggest that we should follow the COVID appropriate behavior even after getting vaccines, so that it can reduce the transmission. That's all from my finding. Thank you.
Hello, friends. We are back again to continue the session on the science of the pandemic, the importance of data to recognize the features of the pandemic at the local level, and the actions that may be necessary. You've already heard in a series of talks where we were we were informed and educated at length by the likes of Dr. Manoj Mudhekar, Dr. Neem Pathi, Dr. Sandip Mondal, and to conclude this series of lectures and with us today would be somebody who is extremely valued, respected, and regarded in the epidemiology circles of our country, and that is Dr. Samiran Panda. Dr. Samiran Panda, who's one of the senior most scientists with the ICMR on the epidemiological side, has been a director of the National AIDS Program and very, very intimately involved with the ongoing monitoring, actions to be taken, and trying to project and guide all of us as what should be the future trends and public behavior in COVID-19 as it stands today. So without much ado, I think I am as keen as all of you are to listen to Dr. Panda. So Dr. Panda, we are absolutely grateful to you for sparing your time this afternoon. And please, we are all ears to listen from you on the importance, on your assessment of the current situation. How are you looking at the data in front of you? What are the actions taken? Dr. Panda, please. Sir, please start.
Well, thank you very much for inviting me to this interaction. And we all have questions, and we all would like to have one who would have answers to all the questions that we have. Unfortunately, this is a disease and a virus which is now a pandemic all over the world, which did not come out of a textbook. Because the diseases which are written in the textbook, human civilization has got experience with for quite a considerable period of time. We have been able to identify the causative agent and the modes of transmission. I'm talking about the infectious diseases mostly. And for those which have been with us for quite a long time, we have certain answers. But this particular disease, which is a new one, and the virus is also quite new. So it's almost like we have started a voyage, a journey on the ocean, where we are in the process of building the ship. So the ship is not yet built fully. We have just got a few planks tied together and we have started sailing while still making the ship or building the ship. So basically, it's knowing a bit of it and trying to take rational steps based on whatever incremental accumulation of knowledge that is happening, and trying to see or know much more about what is in there in future. So with that preamble, I would say that India, as in many other countries, are in a phase where the second wave is still not over, and everybody is keen to know, is it gone and we are ahead of the second wave of the epidemic, or is there going to be a third wave or not? But the situation we are in now, that doesn't need any elaboration for any one of us who is in India. We did have a smaller first wave, which sort of dwindled down after September 2020. And then there was this gap of 4 months approximately, following which there was a bit of thinking that maybe it's end game, the epidemic is over. And then came like a bolt from the blue, a second wave, and that attained a peak, which is about 4 times high compared to the first one. And that was May this year, mid-May. February it started, and then it sort of peaked in mid-May. And it has started coming down, and countrywide, it's a few thousands which have been reported, around 30,000 or so. It was sort of hovering around 40,000, and then came down a little bit. But then the question which everybody is asking, is it over? Is it the end of it? Or is there a possibility of a third wave? Are we going to see a third wave? That's the question everybody is posing to the scientists who are in the thick of it, or the physicians, nurses, healthcare workers, policymakers, program planners. Now, when we ask this question, are we going to see or experience a third wave? Who are we? The other framing of the question could be, is India going to see a third wave? First of all, I would say that as the whole world and the human civilization can now be divided into two, pre-COVID human civilization, or the planet we live in, and the post-COVID, similarly, there is no more one India. Why am I saying that? While there was this first wave, every Indian was susceptible. So there was a meaning to it. India is experiencing a new disease, which is COVID-19, and the causative virus is SARS-CoV-2. And everybody was susceptible, and so India was facing something new. But the way the second wave came in, the month of May, the peak happened in the month of May 2021, it did not have it spread homogeneously across the country. 10 states contributed to the 80% of the infections that was recorded within India. Why am I making this point? So the short and brief answer to this question, are we going to face the third wave? My answer would be yes and no. Yes, for whom? Yes, for those states which did not experience an intense second wave. And no, for whom? No, for those states, those 10 states which contributed 80% of the infections during the second wave, recorded infections during the second wave, because it is not only a huge number of population have been infected there, and that's how acquired some form of immunity. And of course, on top of it, there is some contribution from the vaccination. So they do not have much susceptible population left. So we are now seeing heterogeneity. So there are states which might experience a third wave, because by drawing upon the examples of Delhi and Maharashtra, who actually did see a very intense second wave of the epidemic, they instated the restrictive measures, state level and district level restrictive measures, and that's how they did not allow the infection to run uncontrolled in those states, which is a good thing. However, the other part of it is that the considerable number of population in those states have remained vulnerable. So they are the states, and those are the states which could experience the third wave if the restrictive measures are lifted prematurely, number one. And number two, while a decision is taken for lifting up the restrictions, the vaccination coverage, if that has not reached the desired level, then there is a distinct possibility of a third wave. So, Dr. Sarkar, if you wish me to elaborate briefly what could be the possible reasons for a third wave if it comes anyway. So we cannot say that India will experience a third wave. It would be much more, I would say, reasonable to say that some of the states which did not see a very intense second wave, they certainly have a distinct possibility. And if they lift up their restrictive measures, early, prematurely, without attaining adequate vaccine coverage, there is a possibility of third wave. And then there are 4 situations by which a third wave could come in. Number one, the states which already had very intense second wave, but the immunity acquired post-infection or immunity acquired post-vaccination that wanes after 9 months or so, there's a possibility, because the immune population is again contributing to the susceptible mass, because the immunity is not up and about and kicking. The second possibility is a new variant which is able to escape the immunity which has been acquired post-infection and post-vaccination. The third scenario is a variant which is having tremendously high transmission efficiency. And the fourth scenario by which a third wave could happen is premature lifting. These are the 4 scenarios which mostly have been discussed by us. We did a modeling exercise in collaboration with the Imperial Medical College, London, Imperial College London, and the ICMR, Indian Council of Medical Research. But the 5th one I want to highlight, which is not talked about much. I'm sure Dr. Sarkar, you and others in the audience, and I did not know whether you knew about this English term. At least I learned it from the media when they started talking about revenge travel. What is a revenge travel? You are locked up, you are frustrated. Somebody has, kept you in the room, locked up. You are not allowed to move freely. And when you see that, okay, things are not that bad, and the lead is opened, you rush and you go to maybe Darjeeling, or South Himalaya, the tourist places of the towns you visit. What happens there? So this is a situation, the South Himalayan, at the foothills, there are sleepy towns which are mostly tourist spots, beautiful place, they're blessed, and it's like a respite from this hot summer, hot and humid summer of Calcutta maybe, or Chennai or Mumbai. So what we do, we go in a large number to those cities or tourist towns of the states which are not densely populated. So the large number of tourists moving to a different place actually almost like overnight increasing the population density. So it is creation of an environment, a conducive environment for the virus. For the virus, what does it want? A dead man doesn't cough, right? A dead man doesn't talk. A dead man doesn't sneeze. A dead man doesn't sing. So for the virus to be able to spread from one human being to another, it needs people to be mixing with each other without any COVID appropriate behavior. And so when the tourists go from one place to another, increase the population density, it's actually increasing the chance of transmission for the virus. So that's a 5th scenario. So if we start traveling in the name of revenge travel, because we have been kept locked up for so long that we are frustrated. So we could also sit back and think, is it the time for revenge travel, or we should do responsible traveling? Because the traveling should not be for my own pleasure. It should also have responsibility to we should be all responsible, fellow human beings in the countries, fellow citizens. We should be responsible for them. So the responsible traveling would require us to think that, can we afford to do something which would be damaging for those tourist spots and the travel destinations which survive mostly through the earnings of the tourists? So there has to be some responsibility attached to it. And what could be that responsibility? So in brief, I would say, well, we are in post-second wave situation. In response to the question around third wave, some states do have distinct possibility, and some are actually seeing a little, upsurge from the descending arm of the second wave, declining arm of the second wave. Thirdly, the four scenarios I have talked about: the winning immunity, and the immune escape capability containing a viral variant, or the viral variant which is transmission efficient, and the premature lifting of the restrictions which are now in force in some of the states and districts without attaining adequate vaccination coverage. And the fifth that I'm adding is the revenge travel.
Yeah. So, Dr. Panda, sorry, I was on mute there, that you were so clear and so forthcoming in your comments. I quite liked the start that you did, that this virus was not described in the textbooks. We were hit by a novelty, and so we decided to name it the novel virus. Just off the cuff, that how your community of the epidemic, who are so much involved in the epidemic science, what did you think of the lab-generated hypothesis? Are you inclined to go by that? Are you? I think you are on. Yes.
Yeah, that's a question which is bothering everybody, and globally that's being discussed. So early, I remember during the early phase of this epidemic, there was a study from IIT Kharagpur, if I'm not wrong. The structure of the virus had an indication of proteins from other parasites or organisms, which was not to be expected in the structure of corona, because coronavirus, of course, for human beings, a common man on the street, if you use that phrase, it's something which is new. But honestly speaking, there were coronaviruses which were circulating. It was known to the virologists and the physicians. We know that the birds and the animals, there was a different types of coronaviruses which are circulating or spreading. But we are talking about a particular coronavirus, which is SARS-CoV-2, severe acute respiratory syndrome coronavirus, novel coronavirus 2, causing the disease COVID-19. So the scientists or the virologists expected the structure to be related to the different kinds of coronaviruses which were known to be infecting and staying in the birds and the animals. But there were some unique structural identification that happened. So that actually raised the doubt. Maybe it has been inserted, or there has been some genetic engineering. So really speaking, that wet market in the Wuhan and in China is not really holding much water now. So it cannot be explained as a natural phenomenon. So it's still a question not completely closed and answered. Yeah.
It also seemed to be a part of a very premeditated research project. It didn't just happen.
Gain of function.
Yeah, the gain of function research. Anyway, let us focus on the ground right now, and you've given us a wealth of information. Offhand, Dr. Panda, can you give us a few indications about? Say we are looking at Kerala now, and as you quite rightly say, that Kerala probably did not have the synchronous exposure to the second wave like many sort of classical states of India did, the 10 big ones. Is there any other part of the country apart from Kerala who you think, does Northeast fall within this, that who did not get the classical second wave, or any other areas of the country who you think was not so much heated up during the second wave, who may get the blast in the third wave? Yeah.
You hit the nail right on the head, Dr. Sarkar, I must say. You got it all right, saying that. But the whole problem, I was listening to different discussions, and I kept on avoiding discussions also. Let me be very frank, because in the TV, I was requested, to interact and to reflect upon this. Why did I avoid? I'll tell you that within a short while. But Kerala, the moment we talk about Kerala, we go back to the textbook thing that, oh, Kerala is the best possible state, which is true in health indicators. They are, achievers compared to the other states, all the health indicators. Yes, that's true. But we are talking about a new disease. We are talking about a disease transmission dynamics about which we do not have quite the full understanding of. So we need not to see Kerala as all success story or all failure. That's probably a very unique characteristics of us. We see somebody as good, meaning absolute good, and then bad. There is nothing in between. Although we keep on reading books like 56 shades, 55 shades, 45 shades of life, or whatever.
Yeah.
The point I'm trying to make is that, well, each state, and even for larger states like Maharashtra, each district needs to be examined with regard to the local data and what is the data telling us. Making sense of the data is so very important. Why am I saying this? Because in continuation with my earlier comments, the heterogeneity needs to be appreciated. So the way Kerala is seeing or experiencing the epidemic has or will have the history of the disease and the epidemic which pertains to Kerala during the earlier phase. There is a saying which psychiatrists use mostly, but that's true for many other things and issues in life. Nothing predicts behavior as behavior. Meaning, nothing can predict behavior, but if anything can predict behavior at all, it's the past behavior of a particular person, which helps us to figure out what is going to happen in future. Similarly, if we really are keen to figure out how the virus behavior or the epidemic behavior is going to be for future, the best bait for us or the best course of action for us is to study the past behavior of the epidemic in that particular state. So Kerala should not be compared with Maharashtra, Maharashtra should not be compared with Delhi. So that actually underlines the need or the importance for the state level data, which could help us understand how has the disease spread and where it could go. In terms of, are the districts even within a state are similar, are they similar? If they are not, then we have to take district level actions as well. Because three things actually, I'm sure that some of the terminologies now have become kind of common parlance or common man's language or household terminologies. You go to a vegetable market, ask about RT-PCR, they will explain what is it, or even rapid antigen test, which in a way it's a good thing because people are taking interest in scientific, aspect, which is a good thing. But the problem with it is that we might not have enough time to have the complete discourse or the full understanding of it. So one of that kind of term is R fact, R value.
Yes.
R naught and RT.
Actually, in our series, we had Dr. Mondal, Dr. Sandip Mondal. He talked to us and he explained to us quite a bit about the R number, and he gave us a very clear talk that, and we have been picking up this information that the Delta variant has pushed up the R number from 2 to 4 or more than 4, etc. So, for us who are like half educated, from clinical medicine, we are expressing an interest in public health. So, if you consider that the R number, as you say, has been pushed up by the Delta variant, we are running more or less a complete vaccination rate of around 9%. We haven't allowed 9% at the moment. And the nationwide fourth serosurvey gives us a 67%, give and take a percent on either side as our seropositivity. So, but I think your comment, which should be underlined repeatedly, that do not expect India to behave like a classroom, that 100 children standing up and sitting down. So there will be regional behavior and there will be regional variance. So we are, because each state is like a European country.
Absolutely, Dr. Sarkar. Right now, you highlighted or mentioned about something which is very, very important. The moment you say national serological survey, the fourth round, data, immediately we think ourselves. You see, there is a problem, which is quite understandable for any human being, because if you ask someone, "Who are you?" Of course, 15th August was just 2 days ago. We'll say we are Indian, right? And so if I'm an Indian, so I should sort of relate to the National Serological Survey. And the National Serological Survey, if it says 67%, so we are almost there, meaning towards the herd immunity. Because I'm an Indian and in India, that's the seroprevalence. But is India one country, if we think in terms of the disease transmission dynamics, the answer is no. The answer is no. Because this is an overall average figure that we are talking about, the National Serological Survey. In order to have a national estimate, we did have a few districts from some of the states, and they contributed to the national estimate. But those districts, let's say 4 districts of Maharashtra, 5, which contributed to the national estimate, are the serological prevalence data for those districts be considered? Can those districts data be considered as representative of Maharashtra? No. If we want to have a Maharashtra specific serological data to make an inference, we have to have much larger number of districts sampled and then looked into the antibody prevalence, which will help us to take a solid inference. So that's why National Serological Survey has its own purpose. But each state needs to have its own state-specific serological survey in order to inform decision-making process. In addition to the surveillance for the variants. You did talk about Delta. Delta we have consumed enough, but not again throughout the country. Delta has made havoc in 10 states. As I said, 80% of the infections recorded during the second wave was contributed by 10 states. So the other states which did not see the rat of second wave, if you like it, then they have that vulnerability, and the only way out is to have smart vaccination coverage. I would still say smart vaccination coverage, because there is a difference between smart vaccination coverage vis-a-vis mass vaccination coverage. There is a difference.
Are you a little bit troubled by the fact that our the genetic analysis or genomic sampling rates have not been very high? Or do you wish it was higher, that the number of RT-PCR genomic sampling that is happening? How do you see the situation now?
I'll say that things are getting better. Yes, if it would have been a little more, you would have felt a little more, better, more comfortable. But I would say that, look, if there is a new variant, from our past understanding about the variants, the newer variants, alpha, beta, and delta mostly, there is a gamma as well. But from those variants, we know that whatever be the structural change, the transmission-related dynamics of the strategy, let's put it, the strategy that the virus uses for spreading from one to another, that has not changed much. So we should not focus our attention to the variants. I'm talking about the public health intervention. So the interventions remain the same as yet. I'm not just talking about the COVID-appropriate behavior in the sense of hand hygiene, using a mask, avoiding mass gathering, but also the vaccines that we are using, the Covishield and the Covaxin. They have been tested in the laboratory of the National Institute of Virology, which is located in Pune, and they have been found to be quite effective, although it's not exactly, tallying with the original virus, but they're still very, very effective. So we should not be worrying too much. Of course, the surveillance need to happen. That's INSACOG, that's the body which monitor. And INSACOG is the initiative, the name of the initiative, and NCDC, the National Center for Disease Control, is the nodal body for doing it. And I know personally the director, very efficient director, and really trying hard to ramp it up. But the surveillance, while the surveillance is going, and it's very, very important for us to be able to capture any new variant coming up on the horizon, the earliest possible opportunity. That's called early warning signal. But early warning signal is not just the variant. Let's say we are in a district and we are suddenly seeing many people coming with respiratory illness like symptoms, with symptoms of respiratory illness, and they are getting admitted and they are young. So we do not expect, or maybe they are, children belonging to 8 to 16 years of age. We rather expect children to tackle viral infections much efficiently compared to the adults. And again, young adults are not supposed to suffer that much as we would expect, elderly people above 60 to suffer. But if those kind of clinical phenomena is observed at a district hospital, and so many people are coming, and even there are deaths, you need not to wait for your genetic sequencing to tell you that something wrong is happening. So I'm talking about the sensors in the community, eyes and ears in the community. So sentinel sites need to be very effective.
Right. You see, one thing that has been bothering people in their everyday life has been two aspects. As you said, and you emphasized on it very firmly, that we need to achieve good amount of vaccination and think wisely about a gradual lifting up of various restrictions. So like I'm just narrating to you the situation from Bengal in general, Kolkata in particular, people are quite, a little bit angered and a little bit anxious about public transport, about the local trains. Local trains seems to be dominating our conversation because the government have still kept that under check. So we would like to have the public health perspective on local trains and, of course, schools. How are you advising schools what to do? What's the way ahead?
Excellent questions. Both. Local train. Let's assume that local trains in Calcutta and and suburbs, and local trains in Mumbai, they could compete with each other in terms of creating a conducive environment for viral spread, right? Because you get susceptible people together, and you need to have just a few infected and asymptomatic individuals, and we now know that the virus can spread from asymptomatically infected individuals to susceptible people. And train could be a fantastic place where these kind of transmissions could happen. So before we start traveling, it has to be the state responsibility to ensure that the vaccination coverage attains a level where I would underline two things, where infection transmission could still happen, but those who get infected would not go or advance stage of the disease. They would not proceed to the advanced stage of the disease, because these vaccines are disease-modifying vaccines, not infection-preventing. So acquisition of infection is not prevented by the vaccine. But if I get infected following vaccination, my chance of going and getting admitted to the hospital, or requiring oxygen, or being on a ventilator, or even facing unfortunate event of death would be reduced. So given that, we have to come back to these trains commuting between Calcutta and suburb, or Mumbai, Dadar, and suburbs. So it's a very fine calibrated response that need to happen. So one cannot say that one size fits all. So if the infection has spread enormously during the second wave, and the government has taken initiative in terms of attaining the coverage, and 60 and above, and probably 70 and above won't be commuting in the train, but those who will be commuting in the train will be young adults, because they need to go out because they are the breadwinners for the families. And so if we have attained the coverage amongst healthcare workers, okay, by the way, I want to say that the fourth round of National Serological Survey indicated that 10% of the healthcare workers, healthcare professionals, doctors, nurses, they are not vaccinated.
Yes, very true.
So that's something which we should highlight. So there is whenever we say vaccine hesitancy, we immediately equate with those who are from the villages, not so well educated. Vaccine hesitancy has got nothing to do with education, because you do not have healthcare workers whom we can call quote unquote uneducated. They're educated lot. So
what will you advise schools, Dr. Panda?
Schools. Okay, the schools again, there again, and the national, fourth round serological survey comes, really the results come handy, because we looked into the seroprevalence data in children, because in this round we did cover children from 7 to 17, 6 to 17 actually, and it is almost equal proportion, as equal as adults who are already infected. But what we saw in the hospitals were seeing young adults or elderly coming with the infection and the symptoms, some of whom required admission. But the children, they at the same time got infected, and they tackled or handled the infection well. So I would say that the children are not going to be infected afresh as if they are naive population, unexposed population. No. So they are already infected, and if the schools are gradually opened, there could be 2 or 3 smart ways of doing it. First of all, the parents, if they themselves get vaccinated. Second, the school teachers get vaccinated. Third, the support staff in the school get vaccinated, which includes there are certain school buses and the bus drivers and the support staff. So that will be one thing which needs to be done before opening up the school. Secondly, we need not to have all the students of a particular class and section coming on the same day. It could be split into 2, so you have thinner population groups. So I'm coming back to this whole concept of population density. So you can still have seats kind of alternatively empty. And so you can have one half of a particular class coming on Monday and the next half coming the next day. The other half coming the next day. So that's one. And there have been studies and there have been observations in the UK and other countries as well, which clearly shows that opening up school didn't pose any additional risk to the children for acquiring infection. And we now know that the ACE2 receptors, which are there on the respiratory tract, are much lesser in concentration. And so their chance of acquiring infection is also less. So it has to be based on the school opening decision, has to be based on all these considerations taken together. So it's not just let's open the school or let's not open the school. It's all about the disease transmission dynamics in the adults, what is happening amongst teachers and the support staff, and what is the seroprevalence study, state specific, is telling us. Are the children already exposed or are they not?
I think the last question, Dr. Panda, to you will be that in all your experience from public health and epidemiology, do you think there is a narrative which is going around that we probably are looking at the last 6-9 months or whatever of the pandemic till a threshold level of vaccination is reached? Is that a valid thought, or do we have to live with the fact that this is going to linger in human habitation for some time, and our minds may have to get ready for a longer battle? How do we get ourselves geared up for this?
Well, I wish I knew the answers, but I can draw upon the collective knowledge and wisdom. So we are talking about, whenever we talk about vaccine or any infection, we talk about, particularly in terms of vaccine, we talk about 3 things. One is safety. Is the vaccine safe? Second is immunogenicity and efficacy. Is it producing the antibody and the cell-mediated immune response phenomena? And is it in real life able to protect us from the infections? That's the efficacy. And third is the immune memory, the durability. So about durability, it's a factor of time, right? So how long have we lived with the virus? It's 1.5 years, right? Yeah. And how long have we been living in India with the vaccines? 1 year. Because it all started, or not even 1 year, 16th of January this year. it started. So when we have lived with the vaccine for 8 months or so, we need to wait and see how long does the immunity induced by the vaccinations persist. So I would say that drawing upon our examples from influenza, it might turn out to be the case that the virus stays with us. It's like it goes into from the pandemic and epidemic situation to an endemic state, but it keeps on occurring. So maybe we have to live with the virus, and there might be a necessity of annual boost dose as we see happening or necessary for influenza or flu. But that might be necessary for particular population who is more vulnerable to advanced stage of the disease. So the answer is, well, I do not know. The science is trying to know, but drawing upon the examples and experiences from the flu virus, influenza virus, we can say that maybe we need to live with the virus and we may require. But right now, talking about the booster dose won't make a public health sense. What would make sense is to do the vaccination first dose as well as the second dose, preferably, because we need the full vaccination to happen and the immunity kicks in after 14 days of completion of the vaccination. So right now, I want to start calculating how many doses I need for Indians to have the booster dose, which will be disastrous for public health.
Absolutely.
We should focus on vaccination. We should focus on responsible traveling. We should focus on calibrated school opening and pragmatic measures.
Thank you so much, Dr. Panda. Thank you.
You.
We are so grateful for giving us the time.
It was
Dr. Panda,
nice interacting with you, Dr. Sarkar.